Imagine taking a life-saving drug, right? One that is specifically designed to starve breast cancer of estrogen.
Yeah.
You go through all the grueling treatments, you take the medication exactly as prescribed, and, well, it does its job.
It blocks the estrogen from feeding the breast tissue.
Exactly.
Yeah.
But then you find out that this exact same drug is actively acting like fertilizer in your uterus,
Oh, yeah.
dangerously thickening the lining and, like, increasing your risk of precancerous polyps.
Yeah.
I mean, the very medicine protecting one part of your body is actively threatening another.
It is honestly one of the most frustrating paradoxes in oncology.
Yeah, I can imagine.
And endocrinology, too. I mean, it perfectly illustrates just how volatile the human endocrine system really is.
Right.
Because when you're managing a patient with a history of hormone-sensitive conditions, you aren't just dealing with isolated symptoms.
No, everything is connected.
Exactly. You are managing this highly sensitive, deeply interconnected ecosystem. So a single intervention in one organ creates these like massive biological ripple effects in another.
Which brings us to the core mission of today's deep dive. We are looking at a really specific but incredibly important intersection of women's health, menopause, and oncology.
It's a complex one.
It is. Basically, if you have a history of a hormone-sensitive condition, whether that is a previous breast cancer diagnosis or maybe just severe physical intolerance to synthetic hormones,
Right.
can you safely use a non-hormonal copper IUD alongside hormone replacement therapy?
And to answer this, we're pulling from a pretty dense stack of current medical literature.
We really are.
Yeah, we're synthesizing clinical guidelines from the Faculty of Sexual and Reproductive Healthcare, the FSRH, along with protocols from the British Menopause Society, the Society of Family Planning, and, specialized clinical notes from actual menopause and oncology practices.
Because the stakes for the women navigating this are just incredibly high.
Oh, absolutely.
Like if you are in perimenopause right now and dealing with a hormone-sensitive history, the medical advice you get can feel like, I don't know, labyrinth of contradictions.
It's overwhelming.
You are essentially trying to achieve three distinct and sometimes completely opposing medical goals all at once.
Right. You need to prevent pregnancy.
Yes. And you need to manage debilitating menopausal symptoms like those severe hot flushes and bone density loss.
And above all, you need to protect your long-term health, right? So avoiding feeding a potential cancer recurrence.
Okay, so let's unpack this. To understand how those three goals collide, we have to isolate the variables first.
Starting with the non-hormonal tool you mentioned earlier.
The copper intrauterine device, or QIUD.
Right. When a patient needs to avoid hormones at all costs, this is consistently the first-line recommendation.
Let's get into the mechanics of why that is, because I think a lot of people assume an IUD just sits there physically blocking the way.
Right, like a plug or something.
Exactly. But the copper IUD is actually actively altering its environment without using a single hormone.
That's accurate. The device works through this continuous, localized release of copper ions.
Straight into the uterine cavity.
Into the uterine cavity and the fallopian tubes, yeah.
Right.
And these copper ions are highly toxic to sperm.
It's kind of like an intimidating bouncer at a club, right? It just stands there, altering the environment and stopping entry. It doesn't hack into the club's sound system and change the music.
That's a great analogy. It doesn't change the music at all. Biologically, the copper just interferes with the sperm's motility.
Meaning they can't move.
Right. It's essentially paralyzing their flagella so they physically cannot swim. And the copper also disrupts the enzymes the sperm need to even penetrate an egg.
So it is actively disabling the sperm. But it also triggers a localized inflammatory reaction, right?
Yes, it causes a mild, sterile inflammatory response within the endometrium, which is the lining of the uterus.
Okay.
And this inflammation creates an environment that's rich in white blood cells and prostaglandins.
Which an egg would hate.
Completely inhospitable to an egg. It prevents implantation, even if fertilization somehow miraculously occurred. But what is crucial here, especially for our focus on hormone-sensitive conditions, is what the copper IUD does not do.
Right. It leaves the brain entirely out of the equation.
Exactly. It has absolutely zero effect on the hypothalamic pituitary ovarian axis.
Okay, let's pause and clarify that term really quickly because that is the communication highway we hear about so often in endocrinology.
Yes, the HPO axis.
The hypothalamic pituitary ovarian axis is basically the feedback loop where the brain tells the ovaries what to do, right?
Precisely. In a normal menstrual cycle, your brain sends signals down to your ovaries to mature an egg, release estrogen, ovulate, and, produce progesterone.
Right.
But systemic hormonal birth control, like the pill or the patch, works by hacking into that communication highway.
Ah, so changing the music in the club.
Exactly. Those methods introduce exogenous hormones, meaning hormones from outside the body, into your bloodstream.
Okay.
They travel up to the brain, trick the brain into thinking you're already pregnant, and just shut down ovulation entirely.
Which is exactly what a breast cancer survivor is trying to avoid.
100%.
They do not want exogenous hormones circulating in their bloodstream and potentially waking up like dormant hormone receptor positive cancer cells.
And that is exactly why the CDC explicitly classifies the copper IUD as a Category 1 method in their medical eligibility criteria for contraceptive use.
And Category 1 means?
It means there are 0 restrictions. A breast cancer survivor can use it safely because the copper's mechanism of action is completely isolated to the uterus.
That makes total sense.
Yeah, it provides top-tier pregnancy prevention without adding a single drop of hormone into systemic circulation.
Another thing the guidelines heavily emphasize is the longevity of these specific devices. It's actually pretty amazing.
Oh, it really is.
The sources say that if a copper IUD, specifically one engineered with a surface area of 300 square millimeters or more of copper.
Right, the standard size.
Yeah, if that is inserted when a woman is 40 years old or older, the clinical guidance states it can remain in place for contraception until 1 to 2 years after her final menstrual period.
I mean, just think about the practical application of that timeline.
That's huge.
A non-hormonal device inserted at age 40 could provide highly effective zero-maintenance contraception for well over a decade.
Right.
It literally carries a patient entirely through the chaotic fluctuations of the perimenopausal transition and safely into postmenopause.
Without ever needing to be swapped out or adjusted.
Exactly.
Now, there is one quirky exception buried in the medical texts that stood out to me.
Oh, Wilson's disease.
Yes. The literature notes that the only major absolute contraindication for a copper IUD, meaning the one biological reason you absolutely cannot get one, is this rare genetic metabolic disorder called Wilson's disease.
Yeah, Wilson's disease is fascinating from a physiological standpoint.
How does it work?
Well, individuals with this mutation basically lack a specific transport protein in the liver, which means their bodies physically cannot excrete excess copper into bile.
Oh, so it just builds up.
Right.
Yeah.
Because they can't process it out, the copper dangerously accumulates in their organs, particularly the liver and the brain.
Yikes.
Yeah, leading to severe neurological and hepatic damage. So for someone with that specific metabolic inability to clear copper, implanting a device that intentionally and continuously leaches copper ions into the body is obviously a massive health risk.
Right, of course.
But, for the vast majority of the population with normal liver function, the microscopic amount of copper absorbed systemically from an IUD is entirely negligible. It's incredibly safe.
Okay, so we have this highly effective zero-hormone contraceptive device that lasts over a decade.
Yep.
If you are a perimenopausal woman with a copper IUD securely in place and you suddenly start experiencing severe hot flushes, brain fog, joint pain, you might logically assume you can just start taking an estrogen patch to manage those symptoms and be fully covered.
It seems logical, right?
Yeah, but introducing hormone replacement therapy, HRT, completely shatters that safety net.
It fundamentally changes the uterine environment. But before we get into that, we first need to clear up a very persistent, very dangerous misconception.
Which is?
HRT does not act as contraception.
The doses are just entirely different, right?
Completely different. The estrogen and progesterone doses in standard HRT are designed to simply top up your falling hormonal levels.
Just enough to relieve the physiological symptoms, like hot flushes or vaginal atrophy.
Exactly. The doses are not high enough, nor are they consistent enough throughout the month to suppress that hypothalamic pituitary ovarian axis we just talked about.
So the brain is still telling the ovaries to do their thing.
Right. You will still ovulate on HRT. So you still need a reliable contraceptive barrier until you reach age 55, or until you have been completely period-free for 1 to 2 years naturally.
Which brings us to the real danger zone. If a listener is taking estrogen for her hot flushes and have a copper IUD for birth control, is she fully covered?
Absolutely not.
Why is that combination alone so dangerous?
Because if a woman still has her uterus, introducing estrogen without a counterbalance is a recipe for rapid cellular mutation.
Oh, wow.
Estrogen acts as a biological proliferation signal. When it binds to the estrogen receptors in the endometrium, it signals those cells to continuously divide, multiply, and grow.
It thickens the lining.
Yes.
And without something to signal those cells to stop multiplying, They just keep going.
They do. The clinical term is endometrial hyperplasia, which is a precancerous thickening of the uterine lining.
Okay.
And the guidelines note that if a woman uses unopposed estrogen therapy, meaning estrogen all by itself, up to 20% of women will develop precancerous changes in their uterus within a single year of treatment.
Wait, 20%? 1 in 5 women developing precancerous cells in just 12 months.
Yes.
That is a staggering risk profile for a treatment intended to improve quality of life.
It is. So to prevent that cellular runaway train, the protocol mandates the introduction of a progestogen.
What does that do?
Progestogen binds to different receptors in the uterus and actively counteracts the estrogen. It stops the cells from multiplying, matures the lining, and eventually causes it to shed.
And here is the massive gap when we look at our combination of treatments.
Right.
The copper IUD is fantastic at stopping sperm, but because it is entirely hormone-free, it provides absolutely zero endometrial protection.
Nothing at all.
It does nothing to stop the estrogen in your HRT patch from hyperstimulating your uterine cells.
Exactly.
So if you want to use a copper IUD and estrogen HRT safely, you are required to add a prescribed progestogen, like an oral pill or a patch, to protect your uterus.
Which forces us right back into the hormone-sensitive minefield.
Right. How do you safely introduce a systemic progestogen if you are a patient whose medical history dictates that you must avoid hormones?
Let's tackle this by looking closely at two very distinct groups highlighted in our sources.
Okay.
Breast cancer survivors and women with severe progesterone intolerance.
Starting with breast cancer. We opened by talking about the tamoxifen paradox, so let's dig into the biology there.
Sure. So first we need to establish the baseline rule. HRT, because it contains systemic estrogen, is generally strongly advised against for breast cancer survivors.
That makes sense.
The CDC classifies systemic hormonal contraception and HRT as category 3 or 4 for these individuals.
So basically unacceptable risk.
Right. That means the risks of feeding a dormant cancer cell usually outweigh any benefits.
But the clinical notes from the oncology practices show that this isn't like a hard and fast rule.
It's not. There are instances where an oncologist might clear a patient for HRT.
Like when?
Well, maybe for a woman suffering from premature ovarian insufficiency who desperately needs bone and heart protection, or someone whose menopausal symptoms are so severe she literally cannot function or work.
Oh, I see.
In those cases, a multidisciplinary oncology team might actually approve the use of HRT through rigorous shared decision-making.
Okay, but wait, aren't progestogens dangerous for breast cancer patients too? If they are cleared for that estrogen, they still need a progestogen to protect the uterus.
Yes, they do. And systemic progestogens are indeed a concern. But as you mentioned in the intro, the drugs used to fight the breast cancer often create their own unique uterine risks.
Right. Let's talk about tamoxifen. It's a selective estrogen receptor modulator, or a SERM.
Yes. The way a SERM works is that it binds to estrogen receptors, but its effect actually depends on the specific tissue.
Oh, interesting.
In breast tissue, tamoxifen is an antagonist. It sits in the receptor and blocks actual estrogen from attaching, effectively starving the breast cancer cells.
That's the life-saving part.
Exactly. But in the uterus, it's an agonist.
Oh.
It binds to the uterine estrogen receptors and acts like estrogen, signaling those cells to multiply.
So the drug saving your breast tissue is actively thickening your uterine lining and increasing your risk of endometrial polyps and cancer.
Precisely. So to counteract this dangerous thickening caused by the tamoxifen, oncologists will sometimes turn to the 52 milligram levonorgestrel intrauterine system.
A hormonal coil like the Mirena.
Yes. They place it directly into the uterus so it can locally release a high dose of synthetic progestin to thin the lining and protect it from the tamoxifen's effects.
Hold on, you just said systemic hormones are a category 3 or 4 for breast cancer survivors, meaning an unacceptable risk.
I did.
Why would an oncologist ever put a hormonal coil into a patient actively fighting breast cancer?
Because it's a calculated trade-off of immediate measurable risks. They are choosing to use a locally delivered hormone to directly counteract the known aggressive uterine side effects of the anti-cancer drug.
Wow, okay.
It perfectly illustrates how complex these risk assessments are. The oncology team basically weighs the localized uterine protection against the very small amount of hormone that might escape the uterus and enter the bloodstream.
That makes sense. Which brings us to the second group in our minefield. Women with progesterone intolerance.
Yes.
Our sources state this condition affects between 10 to 20% of women. Why do so many women have such severe, visceral reactions to synthetic hormones?
To understand the biology of progesterone intolerance, we have to look at the actual molecular shape of the hormones.
Okay.
Our bodies naturally produce progesterone, right? And it's designed to fit perfectly into our cellular receptors. But the progestins used in standard birth control pills or traditional HRT patches are synthetic.
Right.
They are engineered in a lab to mimic progesterone, but their molecular structure is slightly different.
I've seen a lot of textbooks use the lock and key metaphor here, but I think a better way to visualize synthetic progestins is like a poorly cut skeleton key.
That's a good way to look at it.
It is designed to open the progesterone door, and it does. It successfully protects the uterus. But because the ridges on the key are cut too broadly as it moves through the body, it accidentally jams itself into other locks.
That is exactly the mechanism causing the side effects. Those synthetic progestins inadvertently bind to androgen receptors, which are the locks for testosterone. And that triggers sudden adult acne and unwanted hair growth. They also jam themselves into mineralocorticoid receptors, which regulate the body's salt and water balance.
So that's the bloating.
Exactly. When those are triggered, the patient experiences severe, painful bloating and rapid water weight gain.
And the neurological effects are even more severe, right? Because these synthetic progestins cross the blood-brain barrier.
They do. Once in the brain, they bind to GABA receptors. Now, natural progesterone usually has a calming sedative effect on GABA receptors.
Like a nice relaxing signal.
Right. But the synthetic, poorly cut skeleton key aggravates them. This can trigger severe mood crashes, intense irritability, and deep depressive episodes.
That sounds awful.
It is. For a woman with this intolerance, taking a standard combined birth control pill or a synthetic HRT feels like losing control of her own body and mind.
So for these patients, the non-hormonal copper IUD is an absolute dream for birth control because it avoids those synthetic skeleton keys entirely. But if they need estrogen HRT for their hot flushes, how do they safely protect their uterus without triggering that severe intolerance?
The modern pharmacological solution is body-identical micronized progesterone.
Body-identical?
Yes. You'll often see it prescribed under brand names like Utrogestan, either oral or vaginal. Unlike synthetic progestins, this is derived from plant sources like yams, and it's engineered to be structurally, molecularly identical to the hormone human ovaries produce.
So it's the perfectly cut key. It only fits the progesterone lock.
Precisely. Because it is molecularly identical, it rarely binds to androgen or mineralocorticoid receptors. It bypasses the acne and the bloating.
That's amazing.
And when it crosses the blood-brain barrier, it binds to the GABA receptors correctly, often producing a gentle, sleep-promoting effect rather than a depressive crash.
So a patient with progesterone intolerance can use a copper IUD for hormone-free birth control, an estrogen patch for her symptoms, and body-identical progesterone to protect your uterus.
Exactly, completely avoiding the synthetic hormones that make her ill.
Okay, so this proves that a copper IUD, estrogen HRT, and micronized progesterone regimen is a biologically viable, incredibly safe ecosystem for these women.
It is.
But functionally, that patient is now juggling a localized medical device, a transdermal estrogen patch, and a daily oral progesterone pill that she has to remember to take. Is there an all-in-one alternative that streamlines this?
There is.
And more importantly, is it actually safe for our hormone-sensitive profiles?
Well, the streamlined alternative is often viewed as the gold standard in modern menopause clinics.
Okay.
It's the 52 milligram levonorgestrel intragradurin system. These are the hormonal coils with brand names like Mirena, Levocert, or Benalexa.
Ah, the device doing double duty.
Exactly. It provides highly reliable contraception by thickening the cervical mucus, which blocks sperm, and drastically thinning the uterine lining.
Right.
And because it is continuously releasing a potent progestin directly into the uterine cavity, it provides robust, localized endometrial protection against the cellular proliferation caused by estrogen HRT.
The clinical guidelines on how long this single device can be used are actually really fascinating.
Yeah, the timelines differ.
For birth control, it is licensed for up to 8 years. But for providing endometrial protection while on HRT, it is officially only licensed for 4 years.
That's the official license, yes.
Yet the FSRH guidelines explicitly support using it off-label for 5 years for HRT protection. Why the discrepancy?
Well, the FSRH strongly supports that 5-year off-label use based on robust clinical evidence. Studies tracking endometrial thickness in women using the 52 milligram IUD alongside various doses of estrogen HRT consistently show that the localized progestin successfully suppresses cell division and prevents hyperplasia for a full 60 months.
So it works for 5 years.
Yes, the clinical reality just outpaces the slow administrative process of updating official manufacturer licenses.
Okay, so if the hormone IUD flawlessly handles both birth control and HRT uterine protection in one simple device for up to 5 years, why would a hormone-sensitive patient ever choose the copper IUD and intentionally complicate her life with daily oral pills?
Because of the reality of systemic absorption.
Ah,
Yes, the hormonal IUD delivers its payload locally into the uterus, which dramatically reduces the amount of hormones circulating in the rest of the body compared to taking a synthetic pill.
but local delivery doesn't mean zero.
Right. Local delivery does not mean zero systemic absorption. A low but detectable serum concentration of synthetic progestin does cross from the uterus into the bloodstream.
And for our specific patient profiles, that detectable level matters.
It matters immensely. For a woman with severe progesterone intolerance, even that microdose of synthetic progestin hitting her bloodstream might be enough to trigger her depressive mood crashes or severe bloating.
Wow.
And for the breast cancer survivor, the oncological data is highly debated.
How so?
Well, some large observational studies suggest the hormonal IUD poses no increased risk of cancer recurrence. But other nuanced studies suggest a very small but potential increase in localized risk.
Which explains why the CDC keeps the hormonal IUD firmly at a Category 3 or 4 for breast cancer survivors. The risks are generally unacceptable.
Exactly.
While the copper IUD remains a Category 1, offering absolute zero hormone exposure.
You are fundamentally weighing the convenience of an all-in-one hormonal device against the absolute biological certainty of zero hormone exposure.
So what does this all mean?
Well, for a patient who has survived a cancer fed by hormones, the profound peace of mind that comes with a zero-hormone copper IUD is often worth the inconvenience of managing a separate, body-identical progesterone prescription.
It is a delicate, constantly shifting ecosystem. You alter one variable, and you must biologically compensate with another.
Exactly.
Which brings us to the ultimate takeaway from the medical literature. If you are navigating hormone-sensitive conditions, can you safely use a non-hormonal copper IUD alongside HRT?
Yes. In fact, if your priority is preventing pregnancy without feeding hormone-sensitive cancers or triggering debilitating synthetic hormone intolerance, the copper IUD is unmatched.
Unmatched. But you have to recognize it for what it is. It's strictly a bodyguard against pregnancy.
Right.
It cannot and will not protect your uterus from the rapid cellular growth caused by estrogen HRT. For that, you will need a carefully chosen, body-identical progestogen.
Managing menopause, particularly with a complex medical history, is never about finding a single magical pill or device.
No.
It's about building a customized toolkit with your doctor, balancing symptom relief, contraception, and cancer prevention. You really have to advocate for your specific biological needs.
Which leaves you with a final, lingering thought to ponder. As medical science advances and we create targeted therapies like SERMs, localized intrauterine delivery systems, and perfectly synthesized body-identical hormones, we still treat women's hormonal health as a rigid balancing act of competing risks.
It's a constant negotiation of side effects.
Right. Will we ever reach a point in women's healthcare where a single non-hormonal treatment can safely address contraception, menopausal symptoms, and cancer risk all at once,
That would be amazing.
without forcing women to constantly choose which side effect they're willing to live with?
Unlocking a mechanism that addresses all three without compromise is the absolute holy grail of reproductive endocrinology right now.
And it is a scientific frontier we will definitely keep an eye on. Thanks for joining us on this deep dive into the complex ecosystem of your health.